There are a lot of diagnoses that are associated with pelvic health, and I don't even know that I've got them all on here, but this is kind of what I came up with, just thinking about it off the top of my head and putting them in alphabetical order. There's a ton of diagnoses, and some of them are rather intimidating. And when I first started working with pelvic health, there were a lot of words that I came across that I really hadn't heard before, and I didn't know what they meant. It's been an interesting trip. There are also a lot of equipment that's associated with pelvic health. And you see some of it here. And not all pelvic health clinicians use this or have this. I don't have anything that's up here. You'll see a little bit more about equipment that I use later. There are a lot of courses that can be associated with pelvic health, at least in the United States. This is from one of the providers for pelvic health courses. And this is not listing everything that you could possibly take in relation to learning more about pelvic health. There's an awful lot of coursework. And for many people, a lot of it culminates into a certification that's associated with pelvic health. So this is in the United States. We have specializations in different practice segments, and the pelvic health has its own board certification. It's an arduous task to get certification in any of them, including pelvic health. And you hear me saying women's health physical therapy. Pelvic health and women's health is kind of interchangeable terms the way that we look at it here. There's also some assumptions that are associated with pelvic health. And what I'm trying to imply here is that oftentimes it's thought that there's always internal work done for pelvic health. Sometimes assumed by the patients, sometimes assumed by a physician, sometimes assumed by the clinician. But it often goes hand in hand. When people think about pelvic health, they're thinking that means internal pelvic health. And when you put all these factors together, this can be pretty intimidating and overwhelming, especially to a clinician who doesn't do pelvic health, who sees these diagnoses, who sees this equipment, who sees all this coursework, who sees the certification, who thinks about it's all internal. And it may be enough to just make a clinician say, you know what, I'm not doing this. I'm not going there. I'll ignore the pelvic segment in the body. But, we work with a whole body. We should. And as clinicians, we can't just say, there's a part of the body that I'm just going to ignore. I'm not going to do anything with that. And if somebody comes up with a diagnosis that is on that list, I'm either going to just gloss over it or I'm going to refer them to somebody else. So maybe they'll come to one person for one diagnosis and go to someone else for another diagnosis that relates to the pelvis. But I wanted to share this, and I couldn't fit any more on here really, as you can see. But this is kind of what my practice looks like. For me, I'm comfortable working with any and all of these, sometimes more with one diagnosis than another, but I put the pelvic diagnoses that I could fit in here. They're in red over there. And I used to not be able to do those, but in becoming more comprehensive and global with how I approach working on the body, it just naturally unfolded the pelvic diagnoses. I really didn't set out intending to get into them, but it just happened when you look at a total body approach. And my training for pelvic is, quite frankly, very minimal. These are some of the instructors that I've had courses with, and I am trained in pelvic internal, but it's very minimal. My training is much heavier in orthopedics. And this is another practice specialty in the United States. I've been a board certified specialist in orthopedic physical therapy since 2000, and I just renewed it again for 10 years, and that takes me to 2030. And after that, I'm not renewing it anymore. Maybe I'll be retired by then. But my training, my coursework, my emphasis has always been much stronger in orthopedics. But as I learned about the fascial manipulation and as I pursued training with it, I went for certification in 2018 and then as an instructor in 2019. I just found myself not being able to exclude that part of the body. It really opened up my practice, and quite by accident, I found myself getting results with these pelvic cases when I had never marketed them. I actually started just bringing that into my orthopedic caseload. And right now, I had to think about this, and I'm not sure how accurate I am, but I guess I would say my current caseload is probably 60 to 70% pelvic. And some of these people come directly to me because I do pelvic work. Some of them come with orthopedic problems, but we draw the pelvic problem into it because I can't separate the two. So it's a real mix in the caseload, but I'm always open to including not just the pelvic, not just the orthopedic, but both of them, because quite honestly, I don't think I can separate them. So I want to tell you a story, and that sounds to me a little more appealing than saying, I want to give you a case report. So we'll call it a story. And in the United States, our tendency is to sort of silo practice, whether we're talking about physical therapy or whether we're talking about medicine, physicians, in that you'll see an orthopedist for one thing. A physical therapist might only work in orthopedics. Another one might only work in pediatrics. Another one might only do pelvic health. But this was a story that I thought would be good for illustrating this whole talk, because this story involves all three of these. So it begins with a 15-year-old girl who was referred to our office for rehabilitation after she dislocated her left patella. And you also see that the prescription read that she had a medial patellar femoral ligament tear. Honestly, she didn't have an MRI, so I think that was an assumption. And she was referred for basic strengthening and what they called extensive patellofemoral rehab. When she arrived, she was wearing a knee immobilizer, and her knee was very swollen, painful. She was on crutches, and she wouldn't bear much weight on the leg. So as I was taking her history, her mom was with her for the first visit, and you asked the typical questions, and I asked, well, what happened? How did you end up dislocating your patella? And she said, basically, she was just walking along one day. She felt this awful pain. It caused her to fall down, and that's how it happened. There was no real trauma, no really good, strong explanation for it. The only thing that I could get out of her that might have had any bearing on it was that she related a month maybe prior to the whole event happening, where her knee felt kind of funky and it just didn't feel right, but she really didn't have anything that even caused her to speak up or say anything about it. So that got my attention as being kind of odd. But anyway, so we get her intake sheet. This is just what ours looks like. I use bright green paper so I can find it easily in the paper chart. And so the left knee was her site of pain. That was her main complaint, her primary complaint. Finally, she told me, after I pushed and pushed for her past medical history, she had sprained her ankle in middle school about 6 years prior. And I really questioned her as to whether she was sure it was the right ankle. She wasn't entirely sure about that, but both her and her mom felt pretty confident that it was the right ankle. In my head, I kind of thought maybe it was the left, and that would explain why then she hurt her left knee. But regardless, I put it down as the right ankle because that's what they said. So we moved ahead with her rehabilitation for her patellofemoral dislocation. We worked on mobility, we worked on strength, and we worked on weight bearing and improving her ability just to walk. And all was going well. I didn't give her stretching because I wanted this to remind me to say that she was hypermobile. And a lot of the people that I see in practice, I don't think my practice is anything different than most people's, but I recognize hypermobility. And I feel like I see it in an awful lot of the people that I see. More female than male, but I see more females than males too, as probably most of us do. So I didn't give her much in terms of stretching at all. I focused more on the other elements. And things were going good. She was moving along, progressing nicely toward her goal of being able to get back to life as normal, until she posed this question to me. And she said this: how do I know this won't happen to me again? And, I thought, for a 15-year-old, that's a pretty perceptive question. That's a very good question, because it really implies that we would understand why it happened in the first place. And remember, this thing occurred idiopathically. We didn't have a trauma. We didn't have an explanation for why this happened. So if we don't know why it happened the first time, chances are good maybe it's going to happen again. And in the whole spectrum of things, there's nobody else who's going to figure out why did this happen. So I accept the challenge. I like challenges. And I thought we need to figure out why a kneecap, a patella, would dislocate all on its own. There's always a reason for things happening in the body. So I wanted to see, I looked at her harder. I took these pictures because I thought someday this is going to be a great story. And here it is. So actually, I've used this several times. And what do you see when you look at this? And I wish I could hear what people say, but I can't. But think about it. Here's what I see. I drew these lines, or I added them on, because this is what I see. I see that she has genu valgus in both limbs, but it's stronger on the left. And remember, the left side was the one that she dislocated the patella on. And she also has a little bit of inversion in the right foot. It's kind of turning in there. So my next question to you would be, why would we see this? What in the world could be driving this for her? Well, lots of thoughts, but mine is it's almost like something's pulling. There's some kind of force that's pulling and rearranging her anatomy. I think I'm got ahead of where I wanted to be. Maybe? Sorry, lost my place. Anyway, pulling. So, nope, I was in the right place. So, some kind of force pulling. So when she started with me, she was so swollen and painful, I couldn't palpate her the way I really wanted to. Everything hurt. But now that she's post-acute and we're ready to go a little bit deeper into the why did this happen, I'm ready to use a different kind of palpation besides just seeing what's generally tender. And I'm looking at tissue layer palpation. I really like using this picture. I use it a lot when I'm talking to patients and teaching classes because I think it, even though in the body it doesn't look quite this neat and orderly and layered, it depicts what's going on pretty well. And what I like to point out is that what I'm really interested in, yeah, these tissues need to be considered, but for the moment, I'm going to focus on the deep fascia. And it looks like one thick layer in here, but it's really not. It's multiple layers, like we can see on this image from real-time ultrasound. So here's the deep fascia showing in this part of the body 3 layers that have some separation and space between them. Here's the muscle, the superficial fascia, which is bilaminar, and then up at the skin, pretty much like what we just saw in that depiction in that drawing. And that's what I'm palpating for. And really, if we break down the 3 layers, what we see here on the medial aspect of the elbow from this cadaver sample is you get a sense that there's different directions to it. And that's because it's collagen fiber bundles laid down parallel to each other by layer, but each layer is facing a different direction and thought to control movement in that direction. But there has to be space between the layers and there has to be slide. And the A on the left side, I guess it is showing that. That's normal function, what we want. B would depict or show a densification, where instead of there being space and slide, it's compromised. And we've lost the space and things, instead of sliding on each other, are adhered together. And my patients always want to know, why does this happen? How did this happen to me? And I tell them, overload, like this poor little donkey here, or whatever he is. Overload. An overload looks like maybe it happens from an injury or a trauma, like my girl with her ankle sprain, repetitive movements or immobilization, where the viscosity of the ground substance just gets changed and things can't move the way they're supposed to anymore. So in her, I'm very interested in palpating this way, feeling for those deep fascial layers in the segment of her knee. Knee is represented here as GE for genu. It's Latin. And I'm not interested in everywhere around her knee. I'm interested specifically in these points where there's either a center of coordination or a center of fusion, which I have labeled here with different colors and different shapes. And I want to know, is there a densification that's happening here? I'm not as concerned if it happens over here. I'm mostly concerned about these precise points because they're going to have more of an impact on movement. Now, I'm trusting that perhaps many, if not all of you, are at least a little bit familiar with these constructs because I didn't want to spend all my time introducing them and reviewing them. I put this one slide in to just say that those points are arrived at by looking at where there are muscle spindles and where they are fired in order to make movement happen in a segment in one particular direction. That's what the triangles are. That's what the circles are, sort of. And it comes together at that one point. That's why I'm interested in that. And there's a lot more information on this that goes deeper in other webinars. So on her, I palpate the segment of genu, and here's what I find. The colors are a little close, but I hope you can tell that I find her bilateral, both knees, anti meaning the front, lateral meaning the outer aspect of the body, and genu for the knee. On the On anterolateral genu, I find it on both sides. On the left side, the side that she hurt, it's on the back side as well for retrolateral genu. But I have more to do. So remember back to that ankle sprain in her original drawing. Now, I'm still not trusting completely that it's the right side. I'm a person who likes to palpate both sides anyway. It helps me be sure of what I'm feeling, but it also helps the patient feel the difference between the right side and the left side. So I palpate both sides. And again, I'm in this same construct of I'm only interested in these points, the centers of coordination, the centers of fusion in the segment of talus. And here's what I find on her. In both ankles, she has densification, but it's actually worse on the left side than the right. Now, is that really the side that she sprained? I don't know. I'll never know, but it doesn't really matter. That's what I'm finding. So now that I've got stuff in both legs, I'm kind of thinking, well, a right leg, a left leg, I wonder if there's something in the middle. Because after all, between the two, there's a pelvic segment that may be harboring some dysfunction as well, and that might be why she has problems on both sides. So I go back, and you haven't seen the flip side of her pain diagram, and I'm going to give this to you enlarged, but what she finally told me after I really pulled it out of her and her mom is that she had some dysfunction in the endocrine system. So she had what's called dysmenorrhea, which is basically just the big name for she had a dysfunctional menstrual cycle. Her onset, or the name for it is menarche, was at age 11, which isn't abnormal. But what is abnormal is that she suffered with heavy bleeding, pain. She missed school. She missed social activities. They put her on multiple oral contraceptives, pain pills. Nothing helped. She lived with it for 2 years, and finally at the age of 13, they inserted an intrauterine device, which worked wonderfully for her. But that's a very drastic measure in a 13-year-old. So that told me, yep, there's something in the pelvic segment. So here was my hypothesis of what perhaps went on with this girl. I'm thinking, I like a timeline. That's what I tried to draw at the bottom there. Now, the first thing that happened was she sprained the ankle in middle school. Second thing that happened was she had her onset of her menstrual cycle, and it was manifesting immediately as dysfunctional, maybe because of unresolved problems down in that right ankle. And then finally, the problem continues to spread and manifests as her third problem, now with this idiopathic dislocation in her left patellofemoral joint. So that was my hypothesis, and I went ahead and palpated the segment of pelvis or pelvis, and this is what I found on her. And I'm, again, back to the same construct with the centers of coordination, centers of fusion. And I found that these were densified on her in the same tissue line as what I found in the lower extremities, that antilateral line. So I went to work on her, and we worked on all the sites that I found, not necessarily in one visit, but I just captured a few with some photos of working on antilateral, the diagonal. And I also, this might be a little different for some people to see, but I use these people in treatment partly because I run behind and it helps. So I have her using a hypervolt. I like percussion tools. I think they help prep the tissue so that it doesn't take as long to then manually shear it and restore that normal space and slide. But it also, I think it gives a little bit of a distraction because what I'm doing on her right knee hurts and what she's doing on her left knee doesn't. I just think it's good too to let them participate in their care, especially when I'm working with a 15-year-old. She enjoyed it. She would sit up, and what I would do then is switch sides. I'd go do the manual work on the left while I had her do percussion on the right. And I'm working on the right knee, partly because I found dysfunction there, but I like to think that what I'm doing there is preventing her from dislocating that patella at some point in the future. And if you remember back to my comment about the hypermobility, that has a lot to do with, I think, why she dislocated, because her tissue just doesn't have the normal stops to movement. You put a densification on top of hypermobility, and it can pull and do anything. So this was just one treatment session and what it looked like. So this was on her last visit with me. I saw her for 6 visits, and she was happy, excited, doing well, certainly out of her brace, walking much better, feeling better. And she did a squat for me, and I know this was upon arrival because she's wearing cutoff shorts. And I don't treat people in cutoff shorts because I can't work through it, and it's too hard to work around it. So I had her change into some stretchy shorts, sports shorts, and then I treated her, and then this is what happened after. She almost fell down because we got that much more accomplished with her mobility. And she wanted to take the picture again. I said, nope, this one's perfect. I love it, because it showed that she got further change. So she really did very well with it all. Now, I can't know what's going on with the dysmenorrhea. I doubt I completely resolved it as much as I would like to, and maybe I'll see her again at some point in the future. But at least it was a start for helping her knee, and I think a start for helping some of her dysmenorrhea. So now, answering this question for her, I can't say I got it all taken care of, but I feel like at least we're making an attempt to get at what might be a probable cause, some of the root behind the problem. So here she is, full squat, and that's my little dog down there too, and doing well as far as I know. I follow up for 6 months, but I haven't talked to her for a little bit. So hopefully she's doing very well, and I'd love to see her when she's ready to maybe try to have kids and see how she's doing with the dysmenorrhea and resolution of that. So that's my story with her. And I want to share a little bit from, this was a summit. Maybe some of you saw this, with lots of good presenters, including Carla Stecco. And her part was on the pelvic floor fascia. And this segment of it, she was talking about interaction between the musculoskeletal system and the visceral mechanism. And she talked about 3 possible mechanisms for a relationship between the two and what those would look like. The first one she talked about was points of fixation through ligaments or anchorages. And for me, when I'm trying to explain to a patient why I'm doing what I'm doing, I'll often use this picture. And I'll talk about the fact that, our organs, they're inside of us. They're not just free floating around in there. There's a lot of fascia that relates them to each other, connects them together appropriately as needed, but it's also anchored to the trunk wall, so that when you turn on your side, when you turn a cartwheel, when you move around, your organs just don't jumble around as individuals, or they don't jumble around as one big mass. They have to be fixed to the trunk at very precise points. And if we know where those points are, which is what some of these points are, then this is how we can have an impact on the underlying organ by working externally. I often tell people it's really not the organ that's the problem. It's the environment that the organ is trying to function in. And that's why maybe a lot of these tests that look at the organ don't show anything, because the organ's not the problem. It's the environment. So a second point that she presented in this whole construct of relationship between musculoskeletal and visceral is the concept of the container and the contents. And I liked this illustration that she brought in of just thinking about like a water balloon. And maybe we're talking about the bladder here, but we could be talking about the stomach. It's kind of all the same. But that these organs are inside this container, the trunk, and they're counting on the muscles and the fascia to be elastic, adaptable, and to allow them to move, modify their volume, because your bladder, your stomach, your colon, all these organs change in size, and the trunk has to be able to accommodate that. So if there's rigidity in the trunk, it's going to be like this rubber band around this water balloon. It's not going to be able to accommodate it. And then we feel like there's a problem with the underlying organ when it's really not the organ. She went on to present a third point with this, and this is talking about the distal tensors, which is basically referring to the limbs. And in the case of when we're talking about pelvic, we're really going to focus more on the lower limb, because there's such a strong biomechanical relationship between the lumbar, pelvic segments and the lower limb, because we walk around on them all the time. There's a strong biomechanical alliance between them. There's also a strong anatomical alliance, and that's what she was showing here when she was looking at the continuity between the trunk and then down into the lower limb and even to the contralateral side. And I just pulled out some of her comments and I put them over that same picture, so you're not missing anything. But she was talking about how there's a crossing over. The external oblique fascia crosses at the symphysis pubis, moves toward the contralateral lower limb and toward the medial region, mostly in the adductors. And this fascia is in continuity with the fascia of the pelvic floor. It's amazing. Here, we're just carrying this further down the lower extremity into the distal tensor of the lower limb. The lower limb isn't as elastic. It doesn't have to respond to changing volume of an organ underneath. It has to do more with force transmission. And so the fascia down in the lower limb is going to be not as elastic, but more thickened and have more collagen in it. But what she's commenting to here is that tension can be transmitted through the limb from above to below and from below up. And this is just, I think, a perfect example of it, a hammer toe, that this could be caused by excessive tension coming from the trunk. This could exert a force on the trunk. So it works both ways, from proximal to distal, distal to proximal. And we can work in both areas to impact a change on the underlying organ. So this was a lady I saw for urinary incontinence, among other things, but this is the model that I use, all external work. I worked on her talus there. I think I'm doing antilateral talus as well as antilateral pelvis, it looks like. I put these pictures in of her feet because I wanted to just illustrate the points made earlier that the feet, the lower limb, the ankle, the segment of talus, they're all really important in this whole construct of working with the internal organ through the distal tensor as well as through the canister or the trunk. And she had a lot of dysfunction with the toenails, and you can see how reddened this one is. I like having people take their socks off and let me see their toenails. I document about toenail health, and when they're wearing colored nail polish, I note that, but I ask them about it. So toenail fungus, ingrown, thickened toenails, to me is all a reflection of abnormal tension, maybe even arising as far into the toe as all the way, almost halfway down the toenail. But you can see from her how rigid her arches are. She's got overactive toe extensors, lots of dysfunction for this lady down into her distal tensor. So I threw this in because urinary incontinence, a lot of times people think, well, you need to do Kegels. And, there's not a lot of solid evidence to support that. And there's a lot of people who could attest to the fact that it really doesn't do that much for them. I thought this was kind of funny. This was from, the Women's Health, the section of Women's Health magazine. It's presented, to me, it's the same as if you came into me for knee pain and I told you, you need to do a quad set. I don't know how many, you just need to do 1 million of them, do them all day long, do them forever. It's kind of where people go with Kegels sometimes. But there is a case that I hope I have time to get to with you where I did use Kegels. I don't use it often, but every now and then it has a place. This was another case of urinary incontinence and pelvic organ prolapse. And this woman had significant densifications down into the lower limb, as Carla was showing with, the movement of the fascia down to the medial aspect of the limb. Here I worked on this woman in a site called mediogenu, and she had some pretty significant involvement down there. This is from perhaps a text that you're familiar with, the Travell and Simons manuals on trigger points. And this drawing just depicts, I think, a lot of what Carla Stecco was talking about with the relationship of the fascia from the lower limb up into the pelvic floor that can give you the perception of referred pain into that region. Maybe it's because of the fascia as well and the relationship there. And this is taking it back to that Fascia Research Online Summit, where Carla was talking about how complicated it is, the way that the fascia has different names throughout this area. So I'm just pulling out words over the picture from her comments, that it's complicated because it all has so many different names. There's one name for the fascia of the bladder, another for the uterus, another for the levator ani, or the pelvic floor muscles, another for the fascia of the rectum. And it really makes it hard to process that it's all connected and it's all the same. People focus on the part they deal with and yet don't understand that it's related to another specialties area. Like there's gynecology in there, there's urology, there's internal medicine, but everybody gets in their own compartment and they don't realize the relationship between them all. Taking this further, looking at Scarpa and Colles fascia in the lower part of the pelvis and the continuity of it. She comments that Scarpa's fascia relates very heavily to the fascia of the lower limb, pelvic floor, and all connected. Any type of alteration can bother the organs and the tissues in the lower limb as well as into the trunk. So this is looking at a posterior view of the ligaments and the fascial bundles that are back there. And she commented the external anal sphincter is connected to the coccyx by a fascial bundle. And this might have some impact on the next story that I'm going to share with you. This was a lady who makes me look like a shrimp. She came from South Africa, not to see me. She moved here and she now lives local, but I got to see her and I enjoyed working with her. It was her first baby, overdue, labored 8 hours, finally induced. she sustained a 4th degree perineal laceration, which is about as bad as it gets for tearing. And it's called an oasis. It's a funny name. It's no paradise. It can be pretty debilitating. She suffered from fecal incontinence, urinary incontinence, pain with penetration of the vagina, and understandably an aversion to having any more children. She didn't want anything to do with it. So her past medical history, you can see what's up here, and it kind of breaks my heart because to me, we had multiple opportunities to try to intervene and help this woman so that it didn't go where it went for her. But I didn't get to meet her until after she had that first child with all those complications. But I would suggest to you that this kind of history was signaling a problem that it would have been good to try to address before she ever even got pregnant. But I saw her for 6 visits. We worked on fascial manipulation. We did very minimal exercise. Home instruction for her was the perineal massage. And now that I'm thinking of it, I should have put up here too. She's one I gave Kegels to because she had a surgical site in the pelvic floor. She had sutures. And to me, that's reasonable to give her some work to do for muscle reeducation. It's probably one of the few times that I use a Kegel though. And she had 100% resolution, which was lovely. She was pleased with that. And so was I. And she sent me this email saying, hey, I'm doing good. This was about almost a year afterwards. No accidents, meaning fecal or urinary, and baby's doing good. Everybody's happy. So I don't know if she's going to have another one, but maybe I'll see her someday again. So in summary of that, all those comments from Carla Stecco, basically there's continuity between the visceral fascia and the locomotor system and the trunk and the lower limb. Pelvic floor is not alone. Total continuity, a strong relationship. Locomotor system relates to the internal organs, and that their elasticity is key. You can't just worry about fixing the position of the pelvis. Like, is there a rotation? Is there an upslip, a downslip? Is there a sacroiliac joint problem? Well, I think there's more to think about than just those elements. Elasticity in the trunk is key. Okay, and the literature supports this too. This is a study from our journal, the Physical Therapy Journal, where they basically found that there's association between urinary incontinence and back pain. Another article from the same journal issue, where they looked at hip mobility, and by addressing this, we're able to help urinary incontinence, pelvic organ prolapse. So same constructs. This was a nice article from one of our fascial manipulation instructors in Italy, Andrea Passini, and very similar to my case, actually, my story of a female with dysmenorrhea, knee pain in the one session. These were the points that they treated, and she did very well with that. And across the literature, again, you can find multiple sites. This one looking at 75% of the people in the study reported pain beyond just their pelvic pain, but at additional sites. So it's throughout the literature. All these diagnoses, there's a lot there, a whole lot there. And what I just want to comment to with this is that it's really about the same as if someone comes to you for neck pain or knee pain. You're going to ask different questions, and they just have to be specific so that you can know how to mark change. So when you're talking about bladder issues, for instance, there are specific questions that you'd want to ask. Like I broke it down this way. I can't do every one of these diagnoses, but these are some of the things that I ask about so that I can quantify it. Because it can be hard to measure otherwise. It's not like a movement test or a painful knee. So I ask about pads. I ask about how many times do you get up at night? Is there any unintentional loss of urine? No amount is normal. Men, it behaves a little bit differently. I also put don't overlook the bowels in there because a lot of times urinary incontinence has an element of influence from constipation, and it has to be addressed, especially in kids. Bladder problems, I want to know the history the same as anybody else I'm seeing. Do they have old fractures? Do they have coexisting concomitant issues? Do they have surgical sites anywhere? All of that's the same for all my patients. Inspection, I want to see tibial torsion. I think this was the same person. Look at this point here. It's definitely different from over here. Something's going on. There's a lot of force happening there. Excessive lordosis, back to the toes and the health. What's happening at the shoulders? What's happening at the feet? What about the skin? Is there a leg length discrepancy? All these elements matter. I use movement, but it may not be the most informative when I'm doing a pelvic person because there may not be any movement dysfunctions. but I will check and make a note of it. I really like using a squat because it's quick, it's easy. And what I do 2 steps with it. If this person can squat this far down with their heels down, then I just note that. But if they're stuck up higher, I have them raise up their heels and squat just with the 4 feet on the ground. If they can go a lot further, then that's absolute confirmation to me that there's some kind of restriction somewhere in the foot and somewhere in the calf. I knew I was going to be working there anyway, but it gives me a retest measure. This young lady who's pregnant had pain, sciatica, with getting up on her bed. So that was my movement test with her. So I used a gesture. I palpate. I've already talked about that, so I'm not going to spend much time on that. And in the bladder cases, I'm very interested in the segment of the lumbar, segment of the pelvis, talus, pes, and then of course I may want to palpate genu and coxa because they're in there also, but these are the ones that I'm going to mainly begin with. I'm looking for a relationship and maybe trying to connect the dots or draw a line between them all. In treatment, my first go-to is fascial manipulation. I may be working anywhere on the body, but for the most part, that lower half of the body for the pelvic problems. I also use other things in treatment. Lots of things you see here, exercise. I like hula hoops, therapy balls. We have a laser, and my dogs are my secret weapon, especially with the children. They help make them laugh. I love cupping. Needling can be very nice as well. I have a lot of brochures I've written because I believe in educating people in as far as what's wrong with their body and how they can participate in their own care. And I have a new blog site, website that I just launched, I mentioned earlier, an hour ago. It wasn't working very good for me. I'm not sure, but I think it might work. I think it needs a backslash after life right there. So if you want to check it out, my intent is to educate my patients and give them a source to go to, but also to have it be something that's informative for other clinicians as well, just to guide them along with some of the pelvic stuff, but really not just limited to that. And this is my nod to biopsychosocial. I bring patients here to say, there's a lot of things that play into what might be causing your pelvic problem. We want to change maybe how you're moving, maybe the daily activities. We'll change what we can change in here, and maybe what we can't change won't matter so much. So treatment elements that I incorporate, you see here, these are my go-tos. And I also do a lot with education using these points of intervention for them. And I really like equipping people and teaching them how to participate in their own care. And I use that construct with all these diagnoses. It doesn't matter which one. I just question it and frame it and reassess a little bit differently according to it. I have 2 case reports. I had no idea how the time would go. I'm going to go through them quickly. You can just see some examples of how this works. So this was a guy, ski instructor, really good skier, so he told me, and multiple crashes, lots of injuries, but 15-year history of recurrent kidney stones, always on the right side. Here were his internal dysfunction symptoms. He was really referred for just pelvic flank pain of unknown origin, and that was all I had to go on. When I got his intake, he had so many crashes and all, it really didn't tell me. I was kind of like, well, we're going to be looking everywhere. But I thought this was really interesting. Remember, the kidney problems were always on the right side, and I thought, wow, gee, that's quite a bunion that he's got there. I wonder if it has anything to do with this problem. And here we are back to the lower extremity for taking care of this problem. So these were the points I found the first day. I worked with him approximately 5 visits. I think he didn't show for his last one, but he was doing a lot better by that time. That's probably why he didn't show. Who knows if he'll go for 15 more years without a kidney stone? I don't know. I'd be interested to follow up and see how it goes for him. But he did very well within that short time. I even worked on his shoulder some. These were some of the tools that I used with him. This is a vibration roller. I like having it prep areas so that when I go to them, they're not so tender and painful for people. All right, last one. Little cutie pie here, 4 years old, constipated since birth. So bad that finally the pediatrician said to mom, it's time for daily enemas on your 4-year-old. That is heartbreaking. So she brought her to me. I treated the mom for pelvic problems, and the mom brings the child. That's how it goes. So we did movement testing. It wasn't revealing of anything, but we had a lot of fun with it. And this is what I found. She was an antilateral, retrolateral. We worked on those. I saw her for 1 visit. Taught mom how to use some tools. They had some tools at home, and in follow-up by phone, she did fine with it. The children are very easy to change. So that kind of wraps up what I had ready for you. I wanted to put this up again just so that you can, if you're interested in contacting me, I'm here. I'd love to have you sign up for my blog site. If that doesn't work, just shoot me an email, and at some point I'll try to make it work right. But I think it doesn't have to have a capital F. It does have a backslash on the end, I think. And that was what I had. And this is my dog, one of them. This is Grace. Thank you all for your time, for your attention. And I hope that this might remove some barriers that you might have toward doing pelvic health.